Welcome, friends, to this new episode of NTP Dialogues. We have amongst us Dr. Yaw Adusi-Poku. He's a senior he's a senior physician specialist of public health, and more importantly, he is also the program manager of National TB Control at Ghana Health Service. And Dr. Yaw, as those who are involved in TB control will know, he has led from the front when it comes to fighting TB in Ghana. So welcome, Dr. Yaw. Thank you so much for your time.
Thank you.
And
Thank you for
thank you.
inviting me.
Yes. And Dr. Yaw, we can see you are already on the move. So this is really great. All right. So, Dr. Yaw, this NTB Dialogues, we launched the season 2 because at the midpoint of the SDG commitment. I mean, SDGs and the NTB goal was adopted in 2015. 90 months have passed by and 90 months are left to 2030. So this is why we are featuring 90 for 90 Global Voices series, and we really welcome you in this, and we will look forward to hearing insights from you. So without any further ado, Dr. Yaw, please tell us how to what extent Ghana has progressed in terms of ending TB and being on track to end TB. Over to you, sir.
Thank you so much. Thanks for inviting me once again, and I'm very, very grateful. On behalf of the National TB Control Program Ghana, we are very, very grateful. So the first thing is that for all countries, molecular testing, first line of testing is the way to go. First line of molecular testing. In Ghana, for drug resistant, for all TB cases, the first line is 100% molecular testing for Ghana. And it's a big achievement. Whilst other countries are still struggling using the microscopy as the first line of test. Some are doing a hybrid, combining molecular and then microscopy. Ghana is 100% testing. We have also, because we don't have all the gene experts for the molecular testing every district, we have 169 out of 261 districts. So what we have done is to improve using the sample transportation system. We have about over 1,000 health facilities that see more than 1,000 patients in a year. So we have mapped all this, and we collect samples. When we screen, we collect samples and transport to the facilities that have the molecular testing, the gene expert testing. So this is a very good achievement when it comes to case finding. More especially when we have a treatment gap, a huge one. And if you come to drug treatment as well, so this is case finding for treatment. Treatment outcome, treatment success rate is more than 85% now. So for all those that we diagnose, we make sure that we come about 85%. If we have 100%, 85% of them treat from, that is 2010. In 2022, we have reached 87%. Okay, so we are on course. Coming to drug-resistant TB, what has gone well for us? We are making sure that gene expert is the first line of testing, and therefore we don't start treatment blindly. We start treatment when we are diagnosed with rifampicin resistance first, and then so we move the treatment success rate. Move from in 2018, we're doing 55% because that is when the facilities were getting used to gene experts, and then we have moved up to 82%. Sorry, I need to exit my map, my Google map. I'm sorry. Okay, so I'm sorry for that. So in 2022, we have moved to treatment success in drug-resistant TB from 55% in 2018 to 82% in 2022. This is a huge one when it comes to multi-drug resistant treatment. When it comes to comorbidities, comorbidities, infection with TB, HIV, and then other risk factors like tobacco, alcohol, malnutrition. You see, if you come to HIV, for instance, in 2018, we're doing 21% but we have moved to 40% in 2022. 21% as a co-infection rate. It has decreased from 21% to 14%. Clearly, when it comes to latent TB is a critical area where now the strategy is that for all people who are contact of TB patients, you must make sure that you put them on TB preventive therapy, and so that in 5 to 10 years time, they don't turn up to have the disease. We started with 30% when we started, and now we have gone as far as 95% coverage in TB preventive therapy. The issue has always been funding. Apart from global fund, there's no fund. Unlike other countries where we have funding, USAID supporting Ghana, other countries, and then PEPFAR and all that. That is not so in Ghana. Ghana, the only external financier is the global fund. So this is what I want to say now when it comes to the successes that we have had in terms of the TB program. Over.
Thank you so much, Dr. Yaw. This is really very, very inspiring to me to hear that 100% molecular testing is being done in Ghana. This is really leading from the front. It's really amazing. This is a dream come true. I come from India. In India, in 2022, 23% of patients got, not patients, people with presumptive TB got molecular tests. So 77% had to take a sputum microscopy. So, there is a long way India has come forward, but it's still a very longer way to go ahead. We need to ensure that every person who needs to be screened for TB must be done like is being done in Ghana with the molecular test. So this is really good. So in India, Dr. Yaw, most of the tests, most of the molecular tests which are being done on the only WHO approved point of care and decentralized test, which is the called TrueNat. And of course, we also have Gene Expert and LPA. So, but most of the tests are on TrueNat because it's point of care and decentralized. So I personally saw it working in a PHC. So so what about in Ghana? You have do you have this, or do you use a combination, or is it only the semi-centralized ones? Over to you, sir.
Thank you so much. This is a very good question. So this is a country where, as you know, we started with the gene experts. We will really want to include other molecular testing. We have considered TrueNat. We are also considering other ones that are in the system coming from other countries. But we haven't started yet. Now it's about gene expert. And the reason is this. We had opportunities to write proposal COVID-19. The other side of the good thing, the other side of COVID-19 was the pandemic funds that we wrote that using for gene experts and the color machines. At that time, we're not so, TrueNat, well, Kenya was using TrueNat at that time, has been using TrueNat, but it takes time to get used to. But now, this is what we are considering TrueNat. Yeah, but not now. It's not in country now. Over.
Yeah, thank you. Yeah, thanks a lot. Thanks a lot for that. And really hope that in India also the machines, the molecular tests which we got for COVID-19 are now being deployed in TB and other diseases. So that's what I've heard also, which is great, because these machines are molecular test machines. Most of them are multi-disease platforms. So this is good that this is one of the silver linings of the dark pandemic. So anyways, Dr. Yaw, so you said that the treatment success rate for drug resistance to TB shot up from 50% to 82%. This is remarkable. So is it because of the shorter regimens which are being used, the latest ones in Ghana? Can you please elaborate, sir? What magic did you do? Over to you.
Thank you so much. Thank you. A couple of things. We set up a task force, basically to make sure, and then we had our real-time detection alerts. We call it System 1 in Ghana. Once you detect rifampicin resistance quickly, we track you. Our TB coordinators are on standby to make sure that you are quickly enrolled onto treatment. And thanks to Global Fund, we also the enablers package that is on. What we do now is that once you are diagnosed, we send the full package to you, thanks to Global Fund, for you to do laboratory testing and then to also use them as out-of-pocket expenses. So these are a constellation of factors. The fact that one initial default rate is kept as minimum as possible because we have sensitized all our regions to ensure that once a case is diagnosed quickly, so we have a task force. And then we also have a national health insurance, free national health insurance scheme for our TB patient. So once you are diagnosed, you are put on TB quickly. That is so important. We also have for the intensive phase, we give you therapeutic blended food to sustain you because most TB patients don't eat, most of them are very malnourished. So we have that going for us. And we also make it clear that TB is a family issue. It's not just a one individual issue. So we go to the family and we counsel the whole family that take care of this. We try to destigmatize as much as possible so that the patient can complete treatment. More importantly, we have a strong community affected population, a network who make sure that once you are diagnosed, quickly they take you up. These are civil society groups. They take you up, counsel you, and make sure you complete treatment. Make sure that you do your follow-ups. These are clear milestones that we have. And so this has helped so much. The advocacy, the sensitization. When it comes to the shorter regimen, we have been using the 11 to 9 to 12 months regimen, 9 to 11 month regimen. We are now transitioning to the 6 months, the BPAL-N. So we have a plan. We have met the TB advisory board who has given us the green light to start transitioning. So for the 6 months, we haven't started yet, but for the 11 to 12, 9 to 11 months, that is what we are using. And it's the task force and the collaboration of civil society and family members is what is working. Over.
Thank you so much, Dr. Yaw. This is really amazing to hear, the kind of success rate which can come, and also the way partnerships are working in Ghana. Like, I mean, with the national program is working so closely with the communities, and how I'm very impressed to learn that you first do drug sensitivity testing, DST, and then based upon which drugs will work on the person, the treatment is done, which is really should be a standard practice. So Dr. Yaw, can you now please tell us what should happen the next 90 months to 2030 so that Ghana can end TB before 2030? Over to you, sir.
Sorry, you were breaking a little. If you can please repeat that.
Yes, I will repeat that. What should happen in next 90 months? Because 90 months are left to 2030, so that Ghana can, accelerate its progress towards NTB goal by 2030, preferably before 2030. Over to you.
Yeah, very good question. We want to take a cue from India, where you come from. The government is part of the solution. He has taken it upon himself. I was looking at your data capture, India data capture. We asked the program manager of India, how come you have this robust data capture? And he said that the government paid, of the $3 million that was meant, the government paid 85% of this. So we are coming back to Ghana. We want the president, His Excellency, the president. So we want to take advantage of the United Nations high-level meeting that is about to come on in September, and impress upon the president that one, president, you need to attend, Your Excellency, attend this meeting. And therefore, we have started engaging him on his commitments. We don't want TB to only become a medical disease. When it becomes a medical disease, all the stakeholders say that, yes, do well. I mean, this is medical. Ghana Health Service, Ministry of Health Ghana, take care of these patients because they are your job. No, we want to speak the politicians' language. We want to tell the president that, Your Excellency, TB has a high impact on society. It has a high impact on children who will be the future leaders, the vulnerable in the society, the prisoners, and all the groups, the minors, and therefore we want to invite the private sector in. If we want to say in the language of equity and justice, that is what the politicians understand, equity and justice. And therefore, private sector must come in. Why are they coming in? Because TB disease affects minors. We have what we call the post-lung disease. It's mostly coming from the mining area. And that is where they generate a lot of income. So why can't you buy gene expert for the whole population? So we want to approach this with the mind that TB is a social disease. It affects every person of the population. We want to disaggregate our data according to occupation and know that, and let the president know that we have soldiers, we have doctors, we have lawyers, we have all manner of professions in those that we are treating. Again, we also want to say that it is curable. We also want to have a multi-sectorial accountability framework. Mr. President, you under your leadership, we want to have an accountable framework that we can monitor. So TB disease is multi-sectorial, and we also want to have a social component. We want TB patients to enjoy some of the social opportunities that are in, like the livelihood empowerment against poverty schemes. TB is a pro-poor disease, and therefore they must also enjoy that. We want the president to commit 100% to newer technologies, especially for children, newer technologies and for data capture. So this, in a nutshell, is what we want the president to. We want to involve the president. Once the president speaks, it becomes a policy. Once the president speaks, other stakeholders will come in and say, okay, we have a part to play in the president's speech, because we have now realized that TB is not just a medical disease, it's a social disease, and therefore we must all take part and support. That is how come Dangote in Nigeria can donate about 91 gene experts for the country. Of course, we are talking about 91, so that will be 91 true nuts, 91 biosensors, 91 what do you call it, gene experts. Over.
Yeah. Thank you so much, Dr. Yaw. This is really amazing to hear, especially because TB is a social disease. I think this message really needs to cut across. It's not just a medical disease. It's not just needs a medical solution. It needs a social and political response as well. And we really pray and really hope that your efforts to reach out to the president of Ghana materializes, and under the leadership of the president, the Ghana's progress towards NTB also goes up. So any last final thoughts, Dr. Yaw, before we wrap up?
Thank you, Bobby. My last is this. We need resources. If you look at our national strategic plan, we have a gap every year of $20 million. Our only financiers are the Global Fund. Unlike other countries who are supporting the private sector and so on, we don't have that. So clearly, this is where we come from. The resources of 20 million a gap, what do we need them for? This is translated into molecular testing. So we need more molecular testing. This is translated into digital X-ray. We need more particularly among children who swallow their spittle. So we need newer technology. So the 20 million gap, actually, about 85% will go for diagnostics. The rest of the 15% will go for programmatic interventions. We need support. Over. Thank you.
Thank you so much, Dr. Yaw, again. The very important words, and really hope this happens. And this is the issues which you have highlighted are not only unique to Ghana. I'm very sure that they are very unique. They're also very pertinent and relevant to other low and middle income countries, especially. So thanks a lot, Dr. Yaw, for your time. I know you are saving lives and on the front line of fighting TB in the Ghana under your leadership. So thanks a lot. Really insightful to talk to you. So friends, we were listening to Dr. Yaw, who is the National TB Program Manager in Ghana. He has been leading the TB response for quite a while, and he's part of the Ghana Health Services. So thanks a lot, Dr. Yaw. Let's hope your message reaches the UN high-level meeting, and really pray that your call to have the highest level political commitments to TB also bears fruits. So thanks a lot, and all the best to you, Dr. Yaw, and hoping that Ghana will be able to end TB before 2030, before the target.